Hello, my name's Tim Bienick. I'm supervisor of respiratory therapy at Advent Health Altamont. This is
I am a neonatal nurse practitioner in our neonatal level 2 ICU here at Altamont.
we are planning on doing what's called a little TED Talk today on ventilator modes and why we need to put a baby on it and, and what to do when your baby is out of bed. Uh, Kick off to our education for our 30 weekers. And we'll be coming over to Altamont sometime this year. So what I wanted to start off talking about is what is a ventilator, what it does, why are we putting a baby on a ventilator, and go from there. So first, the first thing is a way we use beeps often, lots of different noises. We put babies on it for a multitude of different reasons. But the main reason that we need for the young ones, we're going to need them to grow, and for the older ones, we're trying to get them recruited and ready to come off the ventilator. So every time we put someone on the ventilator, we want to talk a little bit about the disorder. Can go on.
Um, Basic major reason that babies come to the NICU that we see the most often, the two biggest things are going to be something wrong with respiratory or something wrong with their gestational age that doesn't allow them to have the ability to breathe. The younger gestational babies, their brain is still developing rapidly, so they don't often get the same signals that you and I do when your carbon dioxide increases to start to breathe. So a lot of them like to go apneic. So one of the big reasons that we intubate is lung tissue is not mature yet, and baby doesn't have the drive to continue to breathe. So we have different modes of ventilation that can help with that, starting from basically room air that a baby's on up into being on an oscillator, which we will not be liking here at this facility.
No.
But what we will see when we're bringing our gestational age down to 30 weeks is babies that are going to require more respiratory support, meaning probable intubation for to keep them here in our NICU. So with that being said, we have multiple modes starting. Usually our biggest thing that we see most often in our anesthesia. We often will begin that in the delivery rooms with babies that are showing respiratory distress, whether that be grunting. It's going to be babies that are requiring oxygen. So we're trying to help them perfuse better, open up those lungs and get them transition from an intrauterine life filled with fluid in their lungs to now they're trying to push all that fluid out of their lungs and be able to replace those air sacs, those alveoli with air oxygenated blood in the lung area. So with the 30 weekers, in addition to what we see as that initial distress is going to be that their lung tissue is not actually developed enough as well. So we're going to have babies that have more surfactant deficiency, which we'll talk about in a little bit. And that will be something that will change the dynamics of what we're currently doing. The biggest thing we do see in our units right now currently with babies that are about 32, 34 weeks and about generally is transient tachypnea of the newborn. But what we'll start to see a little bit more is respiratory distress syndrome itself. So difference being transitional type of period of time with extra fluid in the lungs to actually deficient surfactant babies that will require intubation, surfactant administration, and possibly maintaining that ventilator until the lungs mature enough that they can remember to breathe, start to breathe with us, and be able to actually ventilate their lungs much better.
So Sarah, talking about surfactant, with a 32-weeker, it's only do one dose of surfactant. What are we looking at with a weeker?
We usually 3 is usually the highest dosing that we like to do. We like to give the baby a time period to be able to absorb that surfactant. We usually give no more than 3 doses of surfactant. After that, the baby's body should be able to start to kick in and produce their own surfactant. And that's what we're trying to do is support that transient time till they can start to develop their own surfactant. Surfactant is a substance that the lungs produce towards the end of gestation. So 34 weeks and on is when we actually start to make significant amounts of surfactant in our lung. The most we see is 36 to 40 weeks as the baby's preparing for extrauterine life. So any babies born below that 36-week period are going to be at much higher risk for surfactant deficiency. And then there are also conditions that the mom can have, such as gestational diabetes, which we see quite a bit. And actually those high levels of insulin in the mom actually contribute to surfactant deficiency. They're an antagonist against surfactant development in the baby. And then you can have things like meconium. If a baby were to aspirate meconium, it actually deactivates surfactant in the lungs. So All of those things are things where we can now give them synthetic form of surfactant that we make that can rapidly mature those lungs and help them to ventilate better.
A quick follow up with the surfactant. Surfactant is helps your lungs not collapse in on themselves. So all of us have surfactant in our lungs. We actually use it in our dishwasher every day. Like we have surfactant everywhere. Babies just don't have that, especially in under 36 weeks. So it is an important factor utilized to help the babies mature quicker. And the only way to administer surfactant is to intubate the baby. So we have done this frequently in our level 2 NICU prior to it. But just as a quick reminder, we intubate the baby. We confirm placement of the ET tube. We use our markers. We listen to breath sounds. We have our generic tube length that we do it, and then we administer the surfactant catheter that goes down the ET tube. In the past, people may have seen that we flip babies from one side, give the surfactant, bag it in, flip to the other side. The literature has kind of gone away from that. So we now no longer do that. When we are administering surfactant, it's straight up, right down the tube, 2 doses, and we go from there. So most of the time with 32 and above, we've been able to do that in and out surfactant and take that ET out. When we're talking about babies under 32 weeks, it's not going to be the case. We're probably going to leave them intubated for a little bit. So, and that's a good topic to move into our bed modes. So the ventilator, right here is our G5. This is the one that you can see most of the time up in the NICU. It gets really, really big, and other one utilized, but this is our primary machine. There's going to be about 4 modes that you're going to see most of the time when you put a baby in the machine. When we start out, we're going to probably start that baby out on CMV. This is a mode where every breath that the baby takes is going to get the exact same tidal lung that we dial in. And we look to dial in at 5 mils per kilo. So it's very important to get that initial weight so we can actually proper dosage of air that we're going to start them out around 35, 45 per minute. People say it's going to be really a doctor's preference on how we're going to put, how much oxygen we're going to put on that baby. Oxygen is not good for preemies.
It classes something called in premature babies, babies that are generally under 32 weeks gestation, which we're going to start seeing is something called retinopathy of prematurity. And basically the oxygen causes free radicals, and free radicals in the eye, as the eye is developing rapidly, can create aberrant vessels in the vasculature and actually lead to long-term retinal detachment, issues with vision. We may have seen like old days of neonatology when these kids with big Coke bottle glasses was probably helped out by our teens in the early days of not understanding oxygen. We actually use programs across the country, Oxygen with Love, things where we're trying to maintain a baby with the oxygen that they need to maintain a target saturation for that baby. If you see that baby now suddenly going from, starting in 93, 95s, now we're consistently 100. As soon as we see a baby above 95, we want to start to wean down that oxygen to decrease the amount of ROP that we're seeing in our babies, particularly now that under 32 baby is where we watch this carefully.